ADHD. Learning objectives. To gain an understanding of what ADHD is, to understand how ADHD is diagnosed, to be aware of coexisting conditions, and to explore resources and strategies that we can use with children or pupils with ADHD. So what then is ADHD? Attention Deficit Hyperactivity Disorder is a neurodevelopmental behavioral disorder that includes symptoms such as inattentiveness, hyperactivity, and impulsiveness. ADHD facts. 3 to 7% of British children have a diagnosis of ADHD. That is about 400,000 children. Most cases are diagnosed when children are 6 to 12 years old. Boys are more likely to be diagnosed with ADHD. However, it is thought that girls may be underrepresented. 5 times as many of boys as girls are diagnosed. ADHD can go unrecognised in girls. Approximately 60 to 80% of children with ADHD will have at least one other condition, such as autism, social communication disorder, dyslexia, dyspraxia, or learning difficulties. Symptoms of ADHD tend to be noticed at an early age and may become more noticeable when a child's circumstances change, such as when they start school. These symptoms can cause significant problems in a child's life, such as underachievement at school, poor social interaction with other children and adults, problems with discipline, and low self-esteem. The symptoms of ADHD usually improve with age, but many adults who were diagnosed with the condition at a young age continue to experience problems. 30 to 40% of children with ADHD do well as adults, and this percentage can be increased if appropriate help and support is given. The main signs of inattentiveness are having a short attention span and being easily distracted, making careless mistakes, for example in schoolwork, appearing forgetful or losing things, being unable to stick to tasks that are tedious on time or consuming, appearing to be unable to listen to or carry out instructions, constantly changing activity or task, or having difficulty organising tasks. Hyperactivity and impulsiveness. The main signs of hyperactivity and impulsiveness are being unable to sit still, especially in calm or quiet surroundings, constantly fidgeting, being unable to concentrate on task, excessive physical movement, excessive talking, being unable to wait their turn, acting without thinking, interrupting conversations, little or no sense of danger, and shouting out at inappropriate times, such as during a lesson. What causes attention deficit hyperactivity disorder? ADHD tends to run in families, and in most cases it's thought that genes you inherit from your parents are a significant factor in developing the condition. Research shows that parents and siblings of a child with ADHD are more likely to have ADHD themselves. However, the way ADHD is inherited is likely to be complex and is not thought to be related to a single genetic fault. Brain function and structure. Research has identified a number of possible differences in the brains of people with ADHD from those without the condition, although the exact significance of these is not clear. For example, studies involving brain scans have suggested that certain areas of the brain may be smaller in people with ADHD, whereas other areas may be larger. Other studies have suggested that people with ADHD may have an imbalance on the level of neurotransmitters in the brain, or that those chemicals may not work properly. Groups at risk. Certain groups are also believed to be more at risk of ADHD, including people who were born prematurely before the 37th week of pregnancy or with a low birth weight, those with epilepsy, those with brain damage which happened either in the womb or after severe head injury later in life. Heavy smoking and drinking during pregnancy increases the risk of having a child with ADHD, although it is not possible to say that these factors cause ADHD. So how is ADHD diagnosed? There are a number of different specialists a child may be referred to for a formal assessment, including a child or adult psychiatrist, a paediatrician, a learning disability specialist. Who the child is referred to depends on their age and the availability in the local area. To be diagnosed, a child must have 6 or more symptoms of inattentiveness or 6 or more symptoms of hyperactivity and impulsiveness. A child must also have been displaying symptoms continuously for at least 6 months, started to show symptoms before the age of 12, and been showing symptoms at least 2 different settings, for example, at home and at school, to rule out the possibility that the behaviour is just a reaction to certain teachers or to parental control. Symptoms that make their lives considerably more difficult on a social, academic or occupational level, and symptoms that are not just part of a developmental disorder or difficult phase, and is not better accounted for by another condition. How is ADHD treated? Medicine is often the first treatment offered to children with ADHD. Stimulant drugs such as Ritalin and deoxycycline have been prescribed since the 1930s. Psychological therapies such as cognitive behavioral therapy may also help. Strategies and resources. Sit the child at the front of the class away from windows and hallways and corridors. Routine and predictability. Set clear boundaries and reinforce positive behaviour. Be positive and respectful, and keep instructions simple and chunk them. Introduce thinking time to the whole class. Allow children to think out loud. Support social interactions, and be aware of the child's triggers. Use diversion and distraction techniques. The ideal practitioner. The ideal practitioner is knowledgeable about ADHD and accepts that it exists. They enforce rules flexibly while remaining calm and positive. They can modify teaching style and resources to match the child's learning style, and build in as much activity as possible within the school day. They are pragmatic about homework completion and provide opportunities for the child to explore success in areas of ability. They make high and low interest tasks appropriate to child's learning style and know when to ease off when child's frustrations level begin to peak. They speak clearly in brief, understandable language. They run a predictable and organised classroom. They have control of the classroom without being controlling. They can provide immediate and consistent feedback relating to a child's behaviour. They develop a private signal system with child to notify of any off-task or inappropriate behaviour, and can maintain close enough proximity to the child without being intrusive. They can also ignore minor disruptions, knowing when and where not to intervene so as to avoid behaviour escalation. Related conditions: anxiety disorder, oppositional defiant disorder, conduct disorder, depression and or anxiety, sleep problems, autism, epilepsy, Tourette's syndrome, learning difficulties such as dyslexia. Thank you for listening. Here are my contact details. Please subscribe to the channel. Thank you.